Hi, everyone. We'll get started in just a moment. You're at the Silver Hill Hospital Grand Rounds program. Welcome. Thanks for joining us. We'll get started in about 30 seconds as people settle into their Zoom boxes. All right. Welcome, everybody. I'm Dr. Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital. We are absolutely delighted to have you join us, and we extend an extra warm welcome to nurses in our audience today in honor of National Nurses Week. Thank you all for everything you do. Today, in recognition of that, we are pleased to welcome Professor of Nursing at Yale, Dr. Joanne Iennaco, who will present to us on the topic, the impact of aggression exposure on psychiatric workers, a call for changes in practice. I will have the pleasure of introducing her in just a moment, but first, a little bit of housekeeping. Looking ahead, our next Grand Rounds will take place on May 24th, where we welcome Dr. Kelly Postner, who will talk to us on saving lives of individuals, their families, and communities with the Columbia Protocol, an all-hands policy tool, reducing suicide, redirecting resources, and reducing liability. You can review and register for this event and all our upcoming lectures on our hospital website under the Silver Hill Hospital calendar. Back to today's lecture. I am pleased to be joined today by my colleague, Dr. Immacula Can, who is Chief Nursing Officer at Silver Hill Hospital. Thank you so much for joining me, Immacula. We both look forward to moderating a Q&A discussion with Dr. Iennaco at the end of her lecture. During this time, we would love to hear from you and ask you to put forward your questions or comments using the Q&A box. You can submit anytime, either with your name, or you can submit them anonymously, as I said, anytime during the presentation, and we'll get to those at the last 20 minutes of our program. A key component of our Grand Round series is providing no-cost continuing education credits. If you wish to receive CME or CEU, please complete the evaluation survey that will automatically show up in your browser when we end the webinar today, and we'll also email you a copy of the survey. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME-defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. It is now my complete pleasure and honor to introduce our guest speaker today, Dr. Joanne Iennaco, who I learned actually trained at Silver Hill Hospital a while back when she was training in nursing, and knows our program and our beauty of our facility well. So it was nice to chat about that. So Dr. Joanne Iennaco is a professor of nursing at Yale University and director of the Clinical Doctor of Nursing Practice program at Yale School of Nursing. Prior to developing the clinical DNP program at Yale, she directed the Psychiatric Mental Health Nurse Practitioner program. Professor Iennaco holds a PhD in chronic disease epidemiology from Yale University School of Public Health. Her research focuses on the measurement and effects of aggression exposure on workers in inpatient psychiatric and hospital settings. Professor Iennaco is the U.S. lead of the Perceptions of Patient and Visitor Aggression in Healthcare Organizations study, an international study of nursing managers in multiple countries. She's a consultant and clinical interventionalist leading mindfulness-based therapy for insomnia groups in a randomized control trial of MBTI for Black women. She previously was a clinical interventionalist leading CBT for insomnia groups for a randomized control trial, the Heart Sleep Study, and she has worked with Yale's occupational and environmental medicine research team studying the effect of psychosocial aspects of the workplace on health. Professor Iennaco is a psychiatric nurse practitioner with dual certification as both a family psychiatric mental health nurse practitioner and an adult psychiatric mental health clinical nurse specialist. She was recently awarded the 2016 Nightingale Award for Excellence in Nursing. She was a 2010 to 2012 Yale Center for Clinical Investigation Scholar. Her project was on the effects of aggression exposure in psychiatric settings on employee health and work outcomes, which we'll hear about today. She was also honored with the St. Joseph's College Outstanding Faculty Award in 1999 and with a Faculty Service Learning Award in 1998 from the Main Campus Compact. Professor Iennaco is a fellow of the American Academy of Nursing and the Royal College of Surgeons of Ireland Faculty of Nursing and Midwifery. She's a recent president of the American Psychiatric Association, New England Chapter, Nursing Association, a member of the American Public Health Association, the European Violence and Psychiatric Research Group, the International Research Collaboration in Clinical Aggression, Sigma Theta Tau International, and the Society for Epidemiologic Research. Dr. Iennaco's current research interests more broadly include psychiatric epidemiology and occupational mental health. Specific areas include depression, anxiety, stress, suicide, aggression and violence, and the interface between mental and physical health. Professor Iennaco's clinical work as a psychiatric nurse practitioner focuses on young adults and adults with complex mental health needs in her role as an outpatient provider at the Connecticut Mental Health Center. In the past, she has held management and staff roles in adult inpatient psychiatric admissions, emergency department, day treatment, and outpatient settings, and as a visiting mental health nurse. So with that, Dr. Iennaco, we welcome you. Thank you so much for joining us, particularly during this special week. And I know you're probably being asked to talk to many places, so thank you for saying yes to us. And Dr. Can and I will turn off our videos, and we'll welcome ask you questions toward the end and have a chat.
Great. Thank you so much, Dr. Katzman and Dr. Can. I'm really excited to be here with you today to talk about what is a strong interest of mine. As an epidemiologist, of course, I'm very interested in measurement. And so as I thought about various areas I might work in terms of my research, this seemed a very good fit for me in terms of my interest in inpatient psychiatry, aggressive behavior, and I actually, a part of my work role in the past has been to be one of the trainers in terms of how to manage aggression at an inpatient psychiatric hospital. So I'm glad to be here today and sort of talk about what I've learned about this over the years in my work. So my talk is the impact of exposure on psychiatric workers, and we'll talk a little bit about how we might think about changing practice. I do not have any financial relationships to disclose in regards to this presentation today. So our objectives in terms of what we'll cover today is to talk about the current evidence related to the effects of aggression exposure on clinician health in the inpatient psychiatric setting. We'll identify ways to quantify success in de-escalating aggression and how we might use that kind of information for practice improvement. And then what are some of the interventions and things we could do to prevent and manage aggression in our individual psychiatric settings. So we'll talk about education, safety protocols, and how units might collaborate to develop proactive practices and better intervene and support workers in managing aggressive behavior. So the outline, really, I'll start with talking about and defining both aggression and how it's measured. And I'll talk about it from two different frames. One is a patient aggression rate, and the other is the worker exposure rate. So different ways to measure sort of the same kinds of events that are occurring. I'll talk a little bit about the idea of coercion and containment, which we don't hear as much, I don't think, in the US literature, but is a very strong focus in the European literature. Although I think its roots came from, in many ways, some of our intervention strategies that have been developed. I'm going to talk a little bit about common measures of aggression, and I want you to think broadly about aggression, from verbal all the way to physical aggression, and then some of the interventions we might use in those areas. And then we'll talk about preventing and practice improvement. So we have a challenge. And the challenge is that we know that clinicians are exposed to aggression. And we know that this is a dual issue in our settings. It's both an issue of worker safety, and there has been a lot of attention paid recently to workplace violence prevention. And it's also an issue related to both patient intervention. So how do we provide the best care, have the best outcomes, and patient safety? We know that workplace violence is very common in healthcare. There is a 5 times higher rate of workplace violence injury in health and social service sectors. So the United States Bureau of Labor Statistics provides data for us on different types of workers in different areas of industry, and tells us that the rate of lost time due to worker injury is 10.4 per 10,000 full-time workers in healthcare, as compared to 2 per 10,000 workers in all industry combined. So we have this 5 times higher rate. And then when we look at the psychiatric setting, of course, we have about a 10 times higher rate in psychiatric hospitals. So the rate of lost time due to injury is 124.9 per 10,000 full-time workers, compared to 12.8 per 10,000 in all hospital settings. So we have a much higher rate in psychiatric settings. I think all of us know that. We're like, yeah, of course. And this is part of what we do. But we want to also be very aware that violence exposure should not be part of our jobs, right? And so our work is very different than many other forms of employment. Unfortunately, information on workplace or worker violence exposure is limited. And what we have as sort of large sort of national sources of data include workplace injury rates and mortality rates. And in clinical settings, healthcare settings, mortality rates are quite low. We do hear about sentinel events where workers have been killed as a result of violence in the workplace, but the rates of that for our industry are relatively low compared to other industries. But rates of injury, as I just mentioned, are sort of more the focus of concern. And unfortunately, the common measures we use to monitor aggression don't necessarily capture the exposure of the individual worker. So I'll talk about that as I talk about my research and other things I've done. So the bigger picture here as I think about this is, what are the consequences of this aggression exposure on workers? And so we know that there are health effects. We know that post-exposure, there are mental health symptoms experienced by workers. There are actually a proportion of workers who have diagnosable mental health disorders, including PTSD, depression, anxiety-related disorders. And we know that there are physical health problems associated with some injuries that occur. There are also workplace and organizational issues. And so these relate to workplace safety and environmental concerns, as well as work-related outcomes. I'd like to start, and obviously in any research presentation, we want to be very clear on defining what it is we're studying. And so in my work, I've used this, this definition of aggression by Morrison of any verbal, nonverbal, or physical behavior that was threatening to self, others, or property, or physical behavior that actually did harm to self, others, or property. This definition is also used in some of our measurement tools, and one of which is the SOAS-R, which is an incident reporting scale. And I'll mention some data from that I found in my study, but it's broadly used across psychiatric settings to measure aggression. It's actually been translated for use in other settings as well. The World Health Organization has broadly defined aggression and violence as the intentional use of physical force or power, threatened or actual, against self, another person, a group, or community that results or has a high likelihood of resulting in injury, psychological harm, maldevelopment, or deprivation. So some differences here I want to point out. The WHO definition talks about the intention of the act. And actually, when we look at worker injury rates, we're often looking at intentional injury as compared to unintentional workplace injury and lost time. Who also brings up this information about the expectation of a serious consequence as a result of a violent or aggressive event. And then NICE, which is the UK's Institute for Healthcare Excellence, their guidelines from 2015 also define violence and aggression. Their definition also speaks to this expectation of some serious consequence that might be found. And it also speaks to a range of actions and outcomes. So I just want to point out, those are some of the definitions that we have for the idea of aggression. When I'm talking about measuring aggression, I'm talking about measuring the entire continuum of aggression. And so an interesting area is that most of the things that we collect information on are like seclusion or restraint rates, right? Which are sort of the far end of that continuum of aggression. So something has happened, it likely has been physical, there's been some danger to people that we would actually put hands on and either isolate or restrain a person. Important to think about that versus the everyday sort of verbal aggression that happens on inpatient psychiatric units and physical aggression that may occur that may not reach the requirement of intervening in a serious way, like use of seclusion or restraint. I want to mention also the CDC identifies different types of violence. And so I mentioned this just to sort of help you see the type of violence that we're most interested in. So they define 4 types of violence. Type 1 is criminal intent, meaning let's say you're a taxi cab driver and somebody robs you. That would be a criminal intent type 1 type of violence. In our settings, we're most often talking about type 2 violence, which is violence that's perpetrated by a customer or client. And so for us, the patient. Type 3 violence is worker to worker violence. And we are actually doing a better job more recently of studying aspects of worker to worker violence, including bullying and incivility. And actually starting to see that as a continuum as well. This presentation will focus mainly on type 2 violence. And then type 4 is when a person known to a victim commits an act of violence. So for example, I think there was a hospital shooting many months ago where the perpetrator was the partner of a woman who was giving birth. And the violence ended up with killing and injuring people in both the clinical setting, workers in that setting. And then most recently, there has been a further type defined of violence called ideological. And that's sort of for when, if we think about some of the violent acts that have been occurring in our communities and in the world or in this country, often it's somebody who commits an act of violence on an ideologic basis. So with some sort of agenda in mind that doesn't really relate to these other aspects or areas. All right, so in terms of, I talked a little bit about these initial rates here of workplace violence. And so workplace violence is pretty common. The psychiatric setting injury rates are pretty high. And so we see this rate of 124.9 per 10,000 full-time workers of injury in psychiatric settings. And I want you to be very aware that unfortunately, few measures accurately identify rates of aggressive events. And so as we look across the literature over the years, we find a variety of ways to measure aggression. Not all of them are even presented as rates where we actually take into account the number of people over a time period and really specify event rate per number of days. So this is a patient aggressive event rate of 177.9 reported by Lehman in his study per 100,000 patient days. And I'm going to show you some comparative information to this later on from my study, where we used event counters in the inpatient setting to actually count all of the patient aggressive events, including verbal, physical, and not just those that led to additional interventions or measures. We have a lack of measures of worker aggression exposure. Kling reported in 2009 a rate of 8.29 per 100,000 work hours. I'll be sharing a rate that's much different than that. That's a result of our work in the inpatient center with counters. Most of the data that you'll find reports sort of this self-report by workers of their exposure to aggression. And in the psychiatric setting, more than 84% of workers report physical aggression exposure. This should be no surprise to anyone that works in the psychiatric inpatient setting. And 100% report verbal aggression exposure. Now, the importance of accurate measures is that they improve our ability to measure and see the impact of our interventions and to improve our management of these events. So if we're only measuring things like a restraint rate or a seclusion rate or an injury rate, it's very difficult to see movement in those rates over short time periods if we're only having, let's say, one restraint event per month. And this really depends on the setting in terms of what those rates look like. But so to have adequate power in our understanding of what works, we really need to do a better job of measuring aggressive events. And we need to do a better job of measuring aggressive event exposure to workers. And I'll show you some of the data that we have on this. And sort of when we see these wide ranges of from 1 to 70% of workers report blah, 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 what we're finding is that the measures used are not very good, and the time periods are not consistent. And so it's very hard to come up with accurate rates. Okay, so this is a Bureau of Labor Statistics chart that they provide showing the incidence rate of non-fatal intentional injury by another person per 10,000 full-time workers in private industry. And what I just mean to show here is we look across these different social service related workplaces, we see higher rates than all industry combined, of course. And we see higher rates in hospitals. We see much higher rates in nursing and residential care facilities. That shouldn't be a big surprise. Often in inpatient psychiatric settings, it's our older patients with cognitive impairment who may be verbally and physically aggressive. And then we see here this rate in psychiatric and substance use hospitals that is so much higher than other settings. So that's what I'm pointing out. This table is showing by type of worker. So by the job you hold, what is the rate of non-fatal injury involving days away from work per 10,000 workers. And interestingly, when you sort all of the different types of workers, the top three are right here. If athletes and sports competitors have the highest rates, typically unintentional or intent unknown of injury. So it's the football player who gets tackled or injured or whatever, a fight starts within a game or something. So they have the highest rates of non-fatal injury. But psychiatric technicians and aides come in second and third. So this is concerning. And it's concerning when we look at this prior table that showed us overall for our hospitals, it's 124.9, but look at the workers that are having much, much higher rates. I also want to point out for those of you that are working either in home care settings or residential settings, that rates are higher if we remember that healthcare and social assistance rate of 10.4, the hospital rate of 12.8. So I think there's also need for us to be thinking carefully and designing strategies to prevent and intervene and keep these kinds of workers safe as well. Legislatures have tried to develop protections for workers, and actually last year, this act was introduced in the House and actually passed by the House, moved on to the Senate, the Workplace Violence Prevention for Healthcare and Social Service Workers Act. And this act required healthcare settings and social service settings to develop facility-specific plans that involved worker participation, so the workers were engaged in looking at their units of work and identifying what hazards were present and what could be done to improve safety in those settings, with the idea that these obviously need to be tailored to the conditions in particular workplaces. Unfortunately, the American Hospital Association spoke out against this act, which I think had some role in it not being passed in the Senate, out of concerns that some of what was being proposed would have increased cost. And so there's a lot of dynamics associated with what we do in terms of providing protections for workers. The act also would have tried to improve the reporting of events, as well as assuring that there was interventions like debriefing after events and counseling or trauma-informed practices. Now, in many hospital settings, particularly psychiatric settings, we're already doing a lot of these things. But it would have required each setting to look at and have their own specific plan based on their own specific hazards. What I understand, I'm working with a group through the Academy of Nursing that's discussing the issue of workplace violence against nurses. And what we're finding is our lobbyists from the ANA are telling us that this is unlikely to be reintroduced. However, there's a likelihood that OSHA, NIOSH will be working to develop better standards for workplace violence prevention and safety. This is also occurring across other nations. And so in Europe, this group of European medical organizations has called on, in a similar way, the need to prevent violence against healthcare professionals. And so again, this is our rates showing the psychiatric aids here and actually comparing them to a variety of other kinds of workers. And I want to point out the flight attendant rate. So the flight attendants have a rate of 7.8 per 10,000 workers. And what we found in 2021 was an increased rate of violence in those settings. And so they actually got very quick passage of this Protection from Abusive Passengers Act. And this is a quote from the AFA, which is the Union of the Association of Flight Attendants, saying, "Unfortunately, too many of our pilots, flight attendants, and crew members are dealing with unacceptable abuse from passengers, everything from kicking to spitting to biting." And then here's the rates of flight attendant reports of verbal abuse, unruly passengers, 85%. 58% had at least 5 incidents in 2021, and 17% experienced a physical incident. And so I do find it disappointing that we're having less success in healthcare promoting better standards when our events, and this is actually from my study using event counters, showed that workers had on average 6.2 aggressive events per 40 hours worked. So during a work week, they were experiencing, whether verbal or physical, some kind of aggressive event 6 times in that work week. And again, not a surprise probably to most of you out there. And in this setting, also in these adult inpatient settings, 1.7 physical aggression events per 40 hours worked. And so again, just pointing out this, I do want to point out this graph shows physicians, and actually this should say psychiatrists above here, as having a 0 rate. It's not actually a 0 rate. Actually, psychiatrists have a rate of about 0.7, and physicians about I think it's around 0.2 or 0.4. In different countries, this varies as well. For example, in China, the rates of physician violence are much higher. But again, remember that these workers are across all workers in that group. So this includes outpatient settings, not just inpatient settings. All right, so why am I concerned about this? Because there are consequences to aggression exposure and or aggression on our units. And it includes patient or staff safety problems or injuries that occur. There are negative impacts on our milieus. You know, we really need to be thinking about what the impact is of both the violence as well as the preventive measures we're using. There are consequences to other patients. In qualitative studies, patients have identified emotional effects of having aggression on the unit that they're getting treatment in. They discuss feeling angry, shock, fear, feeling depressed, anxious, having sleep disturbances associated with events that have occurred during their inpatient stay. And our therapeutic milieu has problems that come about as a result of the cycles of aggression that may occur in our settings. And I want you to start to think about these cycles of aggression that occur. And actually, you're probably well aware that probably in the initial week to 10 days of admission, rates of aggression by inpatients are higher. And then there are, and typically most patients have maybe one or two events. There is a subset of patients where aggression occurs over a longer period of time. And there's a subset that within this subset are folks who have multiple aggressive events during an inpatient stay, really calling on us to really think carefully about what is our treatment planning, how are we working with folks, and what are our you know, sort of unit plans around keeping everyone safe around this. Unfortunately, when there's aggression on units, we often use coercive intervention. And so I also want to introduce the idea of coercive intervention and coercion as parts of our psychiatric environment that actually do have negative impact. And so we'll talk a little bit about that. And then this is just some information on, you know, the physical assault prevalence when psychiatric staff are asked that they've, you know, and these are sort of rough measures. It's over the last year, over the last 5 years, and we get these high rates of staff being exposed or having a physical assault occur. Physical assaults are associated with low morale, high absenteeism, high turnover. We have a risk in settings at times of a cycle of aggression and actually resulting, if we have a lot of turnover and low staffing, the need to use temporary staff, and sometimes more events associated with this disruption within our therapeutic milieu or community. We also have increase in costs. So we want to think about sort of there are so many things that play a role and so many dynamics associated with this. As workers perceive greater violence threat, there is a greater risk of workers using coercive practices, which may in itself create a cycle of triggering more aggression versus greater engagement, which is really the way out of these cycles of aggression. So unfortunately, we often feel like, oh, we've got to, like, you know, reinforce the rules, and we get more coercive, so to speak. And that may actually detract from our ability to engage with people and actually be more proactive and preventive of aggression. Other consequences. So again, you're going to see these wide rates that I'm reporting here. So these are exposure-related mental health problems that workers report. Again, these are wide ranges. So what this tells me as an epidemiologist is that we have lots of differences in where we're measuring, how we're measuring, what the time periods are that we're asking about. But we do know that after an aggressive event on a unit that a worker is exposed to, more than 68% report they have been moderately to extremely bothered by memories, thoughts, or images of that attack. So this is in physical aggressive events. 95% in this study reported flashbacks. More than 57% avoid talking about it. And obviously those sound a lot like our PTSD symptoms, right? So we do see stress-related symptoms. We see workers worrying more day to day about violence, feeling hypervigilant on units, feeling irritable, anxious, having sleep disturbances, and rating sort of their perception of their own health goes down. And actually, interestingly, in one study, the internal workplace violence was more impactful on folks' perceptions of their health than violence that was external to their workplace. There are higher rates of diagnosis of mental health disorders, including anxiety disorders, depression, and PTSD. There are mixed results in these studies, though. Some studies don't find a significant difference with exposure. And often workers will experience individual symptoms, as I mentioned up here, related to PTSD criteria. In terms of physical health, victims of violence tend to have significantly more physical problems versus non-victims. And so this data that I'm presenting here is based on two systematic reviews, one of which was a meta-analysis of sort of what are the consequences of violence at work. Again, we see a wide range of injury that happens to workers. Locations of injury, most common were head, back, and arm. Types of injuries included bruises, bites, abrasions, scratches, lacerations. And in about 4%, there were life-threatening injuries reported. Now remember that this sounds like a pretty big number, perhaps, but not all injuries are reported. And so some of these, likely, some of my audience today have had bruises, abrasions, scratches as a result of an event that occurred on a unit, but not reported it, right? So there's a lot of underreporting that happens in all of these rates. Okay, so there are also workplace and organizational issues that we have to address. There are safety and environmental concerns. Obviously, aggressive events occurring in our settings will decrease the level of patient safety and can increase adverse effects for our patients, injury for our patient, for example. And actually, studies do find that with improved interventions for workplace safety, workers do have improved work-related outcomes. So it lowers burnout, increases job satisfaction. After events, 4 to 73% of workers identified being afraid of their patients. Now, again, this shows us this huge range. What does this mean in terms of this report? And I think that depends upon the setting you're working in, the time frame we're asking you to report on. So measurement, again, this is not a rate really, it's just a frequency of people reporting fear of their patients. But obviously, this is not something we want in our settings. In terms of work-related outcomes, they include for work performance, low productivity when at work, feeling burnt out, which means likely that workers are disengaging from patients. Again, the opposite of what we want our workers to be doing with our clients. Use of sick leave, low job satisfaction, lowering of commitment to their work. And then there are high rates of workers considering quitting or leaving their job after a violent event or their exposure to a violent event occurs, or quitting their job. And so all of these are really important. A small percent of aggression exposure results in physical injury and permanent disability. And obviously these have great financial impact or economic impact on our units. There is data on this, but the studies of the economic impacts are from quite a long time ago. So I'm not presenting those figures today because I don't feel they're very valid for the current environment. So I guess the point here of all these consequences is for us to think about the interrelationship of both patient and worker safety, and knowing that workers feeling safe at work will directly impact patient outcomes and patient safety. And our approach then to intervention and changing practice means we have to pay attention to both sides. Workplace violence is often met with coercive intervention, which may initiate added violence in our settings. And actually this comes, these are some of the solutions that the World Health Organization suggested: use of incident reporting and learning systems, for settings to identify safety priorities, and then improvement activities to address the problem areas that have been identified. Now, there are many preventive and intervention studies that give us models that we might use as you think about your individual setting, and consider what you might do in your setting to improve both patient and worker safety. I want to mention the idea of coercive intervention. This is actually, I'm part of this European Violence in Psychiatry research group, and the idea of preventing coercion, reducing, eliminating coercion in psychiatric settings is a very focal issue at this time, a priority issue. I think we less frequently hear this. I feel I less frequently hear about this in the US or in the literature coming from our studies. This is just rates of coercive measures being used when patients are involuntarily hospitalized. And this was as a result of a study of 10 European countries where coercive measures were used overall. 38% of patients who were involuntarily hospitalized, 56% experienced forced medication use, 36% were restrained, 8% were secluded. And actually, it's very interesting because across European countries, there are quite different patterns of use. Some countries almost exclusively will use seclusion versus mechanical or physical restraint. So it's interesting to look at and consider that different places are using different interventions to manage and maintain safety when absolutely needed. So to define coercion, the act or practice of persuading someone to do something by using force or threats. So that's from the dictionary. In one of the reviews of coercive intervention, Gouda discussed the intentional overriding of a person's preferences or actions by another person, and usually justifying the action by the goal of benefiting or avoiding harm to someone. So actually Duxbury in her work on both measuring aggression and intervention and intervening with her own model, which I'll present shortly. She talks about the need to also consider that there's a wider reaching use of coercion. If we think about our units are locked, maybe the culture we work in is very rigid. We may be preventing people from using materials because of our concerns about safety. There may be environmental restrictions, and there may be many oppressive approaches that could be referred to as coercive practice. So anyway, that's what we're talking about in terms of coercion. So what are the challenges here? One is measurement, as I've already raised. So we have to be very aware that patient aggressive behavior is not the same as a rate of use of coercive intervention like seclusion or restraint. So in many cases, our settings only measure those rates, right? Or maybe it's the number of codes or the time security was called. There are more aggressive events than even that. And workers' violence exposure is also not equal. It's not the same as the rate of aggressive events, and it's not the same as the worker injury rate. There's actually much more violence exposure that we're not measuring. So workplace violence prevention is another challenge. So what are we doing in our settings to assess for risk of violence, risk of aggression? What are we doing as a preventive in terms of our clinical and therapeutic engagement, particularly with folks who we know to have a history of violence and who may, in fact, who have greater risk in the future then of being aggressive in our settings? And then how do we measure and study de-escalation activities and know if they're effective? So we'll talk a little bit about those. And then there are challenges in terms of what we're doing to intervene to reduce behavior and coercive intervention. Many models exist. And I want to point out that there are many similarities across models. And so what's happening now is the most recent studies are using what we'll call multi-component interventions. And they'll be taking from some of these models and defining for a particular setting or unit the best interventions that will be useful there. And I think that's an important thing for us to think about as we think about our role in violence prevention. And then what are our worker protections and how do we assure environmental safety for workers? You know, do we have alarm bells? Do we have, I know in my outpatient clinic, we have both a wall signal at the Connecticut Mental Health Center to, you know, push if I was in a violent or difficult incident where I needed assistance. I also have a button that's right on my desk that I could push, and there's a place on the phone I can push to call for help. So what are those kinds of protections? How are our environments set up to be safe? And I guess, you know, there's a balance with these protections as well, which are our settings are often not very well funded economically. And our settings are also, you know, we don't want an oppressive setting. So I think we have a lot of dynamics to think about that are challenging as we think about aggression, reduction, and intervention. So this is the measurement aspect of this. So we have both patient rates of aggression and worker exposure to violence rates. Much of the literature only talks about this part down here, which is the number or frequency or percent of patients with aggressive behavior. Very few studies provide us with a true rate, which would be the number of aggressive incidents per patient over a time period, so say per patient day. And very few will specify both verbal and physical events in that rate. For worker exposure to aggression, again, most of what our data is the percent of workers that self-report exposure, which really, in my view, is, I don't know, somewhat meaningless. That doesn't really help us over time figure out are rates getting worse or not. But if we used an actual rate of the number of incidents I was exposed to per hour worked, then we can actually have a much finer measure of, is there an impact of that exposure? If I have a high rate of workplace exposure, then how does that impact my physical health, my work productivity, presenteeism, absenteeism, all those things. And that most of these incident reporting systems, maybe the lost days of work that I've already introduced to you. Sometimes injuries are looked at in terms of who sought medical care. All of those are really underreported. Well, the medical care and lost days are not underreported, although perhaps there's some lost days of work that people do not identify as an event. But incident reporting systems tend to really underreport the number of events that occur. All right, and so I'm giving you here, so from my data, so these are some just general rates, 17% of inpatients are aggressive. This was a recent meta-analysis by Iennaco The range in that of those studies from 35 different studies in this meta-analysis were from 3 to 44% of patients were aggressive, huge range. And they came up with an estimate in the meta-analysis of approximately 17%. 4 to 9% are restrained. This is based on a study in Europe. In my study, when we measured overall number of aggressive events, the staff members using event counters reported approximately 5 events per 10 patient days. That's much higher rates than we typically will see because we're only looking at the number perhaps of restraints in a month, for example. And then the rate of verbal aggression obviously would be much higher than the rate of physical aggression, which is about 1 per 10 patient days. These are some of the scales used, and I included them just that if you're looking at and thinking about doing work in this area, these are the scales you basically should be aware of and that might be useful to you in measuring patient rates of aggression. These are period-based observations of an individual's aggressive behavior, whereas these are like reports, so an incident-based report of an aggressive event, of which probably the most commonly used is the staff observation and aggression scale, or the SOAS, we call it, the SOAS revised is probably the most commonly used. The patient conflict and containment shift report is another interesting measure. I did use these in addition to restraint rates and incident reporting systems in my study, in addition to counters to count events. In my study, again, these are the results here, 15.5 exposures to aggression, to aggressive events, over 100 hours worked for the workers in my study. These were workers on 2 adult inpatient units. And the verbal rate was about 15 times per 100 hours worked, or we could say 1.5 times per 10 hours, so maybe per shift. And then physical aggression rate of 4 per 100 hours worked. When we count this out to what would that look like on a 40-hour work week, it's about 6 events, as I already mentioned. Versus the other data we have is that, well, 43% of workers report more than 1 assault in their career. Well, that's not really very helpful, is it? Or we have this 124.9 per 10,000 full-time workers. So anyway, differences in measurement. Use of a real-time event counter is one way that we might measure violence exposure. And actually, some of the new work that's being done includes like Fitbit type wristbands where people could count an event as they occurred. Or it could be an app on the EHR that the worker can, identify that an event occurred. The POPIS is a scale that that workers are asked to tell us of their perception of the prevalence of events. There are also proxy measures used, which I've identified here. So I'm going to talk briefly about my study, the aggression exposure study, and I'm going to sort of move very quickly through some of this. But the aims of the study, I was actually funded by YCCI and was able to complete this study. We were identifying the incidence rate and characteristics of patient and visitor verbal and physical aggression, which, by the way, all of it was patient aggression in this particular study, and to look at the incidence rate and characteristics of worker exposure from those events that were occurring. And then to compare the feasibility and agreement of different methods. So I'm going to show you some of the rates that we got from this study. It was a longitudinal cohort study over a 10-week period. It used 4 acute inpatient psychiatric units. And we had a convenient sample in the study of 137 clinical workers. They needed to be working for more than 24 hours a week to be counted as a worker. and to use the counters that we are talking about. We did have IRB approval. And this is just a picture of the event counter. And for some of you, perhaps you knit, and you'll recognize this as a knitting counter. And basically on one side, there are two ways to click here. You see this little reel here. As you move it down, it numbers events. So they would press the button for each event that occurred during their shift. And this was on a wristband. It was like one of those coil wristbands tucked under their sleeve. And if an event occurred, I asked them to click the event counter. And so they ended up at the end of a shift with a number of events. We, for intervention fidelity, tried to, we did have training on how to use the counter. And we did regular rounding to monitor data collection and use of the counters. The different measures we used included restraint rates, workplace injury rates, use of the SOAS-R, use of the PCCSR, which I mentioned earlier, and then these event counters and logs. And so we use them to identify the counters to identify worker exposure to verbal, nonverbal, or physical aggression. And it included on the log the date and the hours the person worked, a total number of events, both verbal and physical, the event severity, characteristics of the patient, precipitants, and then there was a single row where people could write about what happened. So this is a picture of our counter, our event counter shift log. And as you can see, we identified some of the characteristics of patients, precipitants, we have age, gender, days since admission, a variety of things. And then this brief description of events, which was very informative as you look at the different events that were counted. Obviously, the procedures, people provided informed consent, and our team members collected those logs, as well as we obtained restraint and injury data of the events. And then this is just some information about how we analyze the data. And so our results, of 137 workers, 91 participated in some part of our study. 57 of those 91 did a consent to use a counter for us, of which 23 were nurses, 16 were psych techs, 10 were PCAs, and 8 were other clinicians. A total of 30 staff members returned logs to us, which is about 53%. And they worked a total of 1,585 hours with an average of 25 hours reported on per week per worker. We got 187 logs back. And basically from this, they reported a total of 244 events over the 2 weeks, 235 or 96% of which were verbal, 67 were physical, and it came out to about 6 logs returned per staff on average. So that is how I obtained those event rates that I was talking about earlier. So this is 3.46 events of aggression per 10 patient days. If you remember before, I talked about layman's rate, right? And so this was a prior reported rate, which I'm excited that they're reporting a rate of 177.9. In our study, if we go to 100,000 patient days, we would have had a rate of 34,640. So this gives you an idea of the identification of events that's being done. And actually, you know, I was kind of puzzled in some of the studies of some of these models of intervention, which are very good models. They were not found, some have not found significant differences post-intervention. And I think part of the reason is this: the way they're measuring so much underestimates the actual number of events that we don't have power to see what's really happening. So I'm not suggesting that every day in every workplace we use a counter, but if we're looking at trying to better understand what's working to de-escalate aggression, which interventions work, we should be very careful about how we're measuring. This is the worker aggression exposure rate, 15.5 per 100 hours worked. As I mentioned before, based on a 40-hour work week, about 6 events occurring. And again, Kling found 8 events per 100,000 work hours. In this study, if I extrapolate out to 100,000 work hours, it would be 15,000 events, which is kind of seems ridiculous, right? But anyway, so a lot of events occur. This is just some data about the patients who were aggressive. I'm going to just flip through this. The counter logs do give us information about what were the precipitants. As you can see, limit setting was the number one. Next to that was medication. And unfortunately, you know, both of these are significant parts of what we do on units every day. In terms of symptoms and diagnosis, we have some data on that. And then, you know, so basically what we found was, yes, workers are frequently exposed, about 6 events per work week. In prior studies, all we really had was that people had been exposed in the past year. So there are much better ways for us to be measuring than what we've used in the past. We have since done a study in inpatient medical units using the same counters. We revised the log to include other things. We included both interventions and consequences of intervention. We also measured whether a missed care event was involved in that. So these counter logs could be used for unique study and setting needs. And then there's in the slides that I know you'll have access to, you can look at some of the pilot data that we found. And again, this shows there were no restraint incidents reported for these 11 shifts where we piloted the counters. We had 8 events, 7 were verbal, 2 were physical. The SOAS had a very similar per event rates, and the PCCSR, which is filled out by the charge nurse, had fewer events noted. One thing that I was curious about and why we did a pilot of this was I was concerned that having worked on a unit, I thought, well, gee, I feel like I always knew if there was an aggressive event occurring. So why wouldn't worker exposure be equal to the number of events that occurred in the unit? And what we very quickly found out was that that is not the case. So we shadowed workers, and actually there was a huge event that occurred. A patient disrobed, got up on the desk. None of us on those units using counters were aware of that event. We got told about it later. It was one of the charge nurse identification of events. So again, how you measure is really important. This also gives you just some basic data. Over the implementation period, there were some restraints that occurred. There were events reported by the SOAS, by the PCCSR, as I mentioned, and then the rates reported by the counters. So when we're using these measures, restraint, the NDNQI data, injury data, incident report rates, we have to remember that these are extreme events at the highest end of our continuum. Some standard measures may be underreported, and in this case, often these are required or obtained electronically as a report later after we study. Using the shift reports, we actually get a nice measure in this scale of nursing care demand. So if you're interested in thinking about this in relationship to what's happening on your unit, it has a place for us to describe the number of admissions, the number of staff members working, as well as the kinds of events that are occurring, the kinds of conflicts, and the kinds of containment measures that are being used. So that's important. I'm going to just flip through these because we don't have a lot of time left to go through this, and I want to get to our interventions. Problems with the SOAS scale is you have to remember to fill out a form after that, and actually studies have found that the rate of reporting incidents declines when you use the SOAS. This is the units that we studied rate of aggression using the SOAS compared to international rates. And so the good thing about the SOAS is there is data internationally on what's happening with aggression in our settings. And then the event counters and logs actually provides a measure of the worker's actual exposure and provides the patient rate of aggression. It allows identification of a trajectory of events for an individual patient over a shift. So may be useful to use when we recognize that the level of aggression is increasing on our units. And it actually helps staff to recognize their exposure in a different way. It was very interesting because in the study period, one of the nurses came to me and he was very excited. He said, Joanne, it's only Wednesday and I've had 12 events. And we've had no restraints, no need to call security or staff assist. What that was showing was the number of events that workers had de-escalated successfully. So it shows the amount of work that your workers are doing, or you are doing, to reduce aggression. And so it validates this part of the work that is largely hidden that we do every day. It also raises awareness of what folks should be doing for their own self-care, that they actually do have exposure. This is a difficult job. This is no kind of walk in the park for our workers. Conclusions, yes, we need to do better in terms of how we're measuring, and especially if we're interested in intervention. So as I mentioned, multimodal interventions are the way to go, I think, in terms of preventing and managing aggression and its consequences. They usually include education and training. The topics of education and training, I think, would be familiar to most of you who ever have taken one. And actually, some of the references that I'm providing will give you an outline of the very specifics of these interventions. They usually have safety protocols involved, and it involves unit-based collaboration and engagement between workers, administrators, leadership in the setting, and our consumers to help to solve some of the problems we have associated with aggression in our settings. And these are some of the interventions that we'll talk about. We also need to separately be very clear that we should be using interventions to support our workers. Education and training can help with this, engaging workers in safety meetings and problem solving, kind of these circles or debriefing, reflection, discussion of intervention, team-based engagement as we think about difficult people to care for and what we're doing about that. I do have, given it's Nursing Week, a link to this mindfulness video for nurses. Okay, so some of the results of some of the studies that have looked at what has been done for prevention program. These are some of the comments made by Peak Asa when she compared California workplace violence prevention programs to what was being done in New Jersey. And California had legislation passed requiring workplace violence prevention programs. And these are some of her findings: that few settings were offering training for all staff. Often physicians and clerical staff were left out. Sometimes topics weren't consistent across hospitals. Administratively, needing to have policies and procedures that address violence against personnel, patients, visitors, and a written plan of what will be done. And so policy is important. Involvement of administration in problem solving around difficult patient care and events is really important. And then she identifies environmental safety controls, and then what should we do in terms of security personnel and their training and what they're involved in. So some things I think we should think about in terms of preventing aggressive behavior is examining coercion in psychiatric settings. Looking at how our patients are collaborating with us and engaging with us, and how our workers are engaging with patients in providing care. What we really want to be doing is improve our therapeutic milieu, improving the unit-based structure and interventions that are being done, and improving how we're assessing risk for aggression so that this should not take us by surprise. These are some of the common risk factors for aggression. And actually, I encourage you to check out the Brosette Violence Checklist as one of the methods to assess risk. There are others that you might use, and including the MOIS is one, which was on that prior slide. So Routine structured risk assessment is one of the interventions we should be considering, and is part of these multimodal interventions. De-escalation training is very important. The problems with this is it's hard to measure because it involves a variety of techniques. And we have to really measure well. We can't just be measuring the problem, the serious, the sentinel events. We have to really have a sense of overall verbal and physical aggression rates. De-escalation training has been found, though, in studies to significantly decrease the frequency and duration of physical restraint. I included some of the materials from these two studies that used multimodal interventions for you to look at and think about as you think about some of the things you might do to change in your setting. And then there's organizational and structural interventions that involve unit environment, staff, patient care initiatives. And really, we need sort of these unit level strategies to make sure, because, you know, in some units, we're doing a lot of things right, but there's a few things we could address that would improve safety and prevent more. So these are the three most commonly talked about multi-component interventions. The 6 core strategies came out in the early 2000s. Huckshorn from the US did a lot of work in implementing the 6 core strategies. I know they've been implemented in hospitals here in Connecticut. It's been adapted for use in multiple countries and has had successful results. Patient days with coercion declined from 30% to 15%, 17% reduction in use of seclusion, 30% reduction in restraint. And again, this is using those big sentinel events. Restrain yourself is Duxbury's model, and she adapted these core strategies to her Northwest England setting and found from a 19 to 64% reduction in restraint rates in 5 psychiatric hospitals. And then there's the Safe Wards intervention, which was created by Bowers. And it's a menu of strategies to implement based on unit needs. So I'm just going to show you some of these strategies. I think what you'll see is a lot of consistency across the models. So the 6 core strategies involve leadership. So leadership has to be involved. So they need to know what's happening in their settings, right? When there's a really difficult patient with repeated events, our leadership needs to be involved in helping staff problem solve and differently manage and figure out how to really better reduce what's happening, the aggression that's happening on the unit. Data use is really important so that we can identify where our problem areas are and then have priorities in terms of what we're looking to reduce or change. Training or workforce development, use of seclusion and restraint prevention tools. There's references here to the model that will describe more specifically what they are. This calls for consumer roles in settings around how best we might intervene with aggression. And it involves use of debriefing after events. So reflection on the event, not in a finger pointing way, in a supportive way, in a discussion of, so this is what we did, how are people doing? What are areas we saw that we feel like we performed well, what worked well, what didn't work so well, how could we, you know, work differently in situations like this or with this person in the future. Duxbury's model is restrain yourself. Again, it's based on those 6 core strategies. And this is how she defined this specifically for her setting. This is showing the blue are the intervention wards. And the number of events. This is this is with implementation and after adoption. So what you see actually, and this is commonly happening if we're not following our interventions long enough, is we may see a rise, and that's because staff are reporting more events. So we want to be aware that that may happen. Okay, and then the Safe Wards model are interventions to reduce conflict and coercion. That was Bowers' model. And I'm going to show you, he has a very, I give you the web-based way to find that model. And actually all of these, there's a full description of the intervention and how to do it, how to implement it on this website if you're interested. And these are the interventions involved. And it's really about how staff and patients are engaging together to reduce conflict on the unit and reduce coercive intervention. Those are his 10 interventions. And then this is there's 2 multi-component interventions recently done. Ye's de-escalation training was a cluster RCT. And as you can see here, use of physical restraint in inpatients decreased in the experiment in the intervention group. This was in 12 hospital units in China. And this is use of physical restraint in patients admitted within use of restraint within 24 hours. So that went down as well. It also, that intervention reduced accidents and injuries caused by physical restraint. And then this is an event. Hi, I'll be done in just a minute. This is a intervention from Slovenia, where they, in 6 hospitals, used 12 units and implemented multi-component intervention. And as we can see, it reduced the incidence of aggression, of physical restraint. It reduced the severity of incidents occurring. And so they had some good results with this. So I guess my conclusions are that we need to be thinking about how are we measuring events? What do we know is really happening on our units? We want to think about when and where and how we use measures. And again, we might use counters for showing whether our interventions are working or not, or whether training is helping us reduce events. There's a variety of ways to use these more refined measures. We may use them when we see an increase in events occurring in our settings. And we may use them to better understand what our staff members' exposure to events are. I guess I want to mention for a moment just the directions for future improvement activities and research. I do think we need to continue working on aggression measurement methods. I think we need to think of aggression as a continuum, not just sentinel events that we're worried about. We want to think about with individual patients, what is the trajectory of this behavior? How did this come about? We want to think about what are our units like, and how can we improve our cultures in our intervention settings and identify specific interventions, because each unit is very different and has its own culture. And so those staff should be working together and looking at what they think the problem areas are. They should be working with their patients and how patients perceive conflict and coercion in the setting, and then thinking about how to reduce the level of conflict and coercion and thus reduce aggression. And then for violence exposure to workers, we need to think about, we need to better measure what is the exposure so that we better understand what the effects are. You know, when we have a range of from 1% to 70% of workers experiences, I mean, that's kind of, to me, kind of ridiculous, right? So there's a lot of room for improvement and figuring out what really is happening in these settings. And then what really is effective in mitigating the effect of workplace violence exposure. So system-specific interventions are needed, and really we have to think about the fact that one size does not fit all, and we need to support our workers. So I do want to thank the workers in hospital that participated in my study. This is my co-authors and mentors and my research team. And I also want to thank you for being with me today. And I want to wish all the nurses happy Nurses Week. I did record a mindfulness exercise for nurses or caregivers. So any of you might find it useful to just reflect on, why do we do this work? And how can we come back to sort of the meaning and importance of that work to us? As well as reminding all of us that we need to use good self-care and use exercises like this to help us sort of better manage our own workplace exposures. So thank you so much. And Dr. Katzman, if you have some questions, I'm happy to answer. And thank you for having me today.
Yes, Dr. Iennaco, thank you for such a wise, brilliant, including your research. I mean, it was just really an awesome presentation. I'm going to start by turning to our leader in nursing, Dr. Iennaco Ph.D, who I know has some remarks and maybe a question. So Iennaco, over to you.
Thank you. Thank you so much, Dr. Iennaco, for such an amazing presentation. Standing ovation I'll speak for the 130 people who are with us today. Happy Nurses Week to everyone, and sincere gratitude again. You know, as a nurse leader, one of the things that I'm always very mindful of is the consequences that, you know, topics such as this, how that's going to impact our staff and also our clients. And I noticed from your slides, one big area that you focused on was, well, you focused on a lot of things, but the consequences of aggression, such as absenteeism, which creates short staffing, staff working longer hours, which then creates the issue of presenteeism. So staff who are on the job, but they're not productive, they're not in tune as to what's happening, and for them to really act on, to mitigate it and prevent certain issues. So if you can speak a little bit in terms of these particular, this issue is very complex, this particular area of what hospitals could do in terms of some strategies and interventions, to address some of these issues. And last but not least, coming from me, I'll also ask if you could also speak of, the high turnover. Is that high turnover, there's a correlation between education and experience, that's really impacting, the high turnover. Thank you.
Yeah, I guess your question makes me think about, with turnover, one of the huge problems we have is loss of that intellectual knowledge of the setting and of how to intervene and how this unit works together to best manage problems in the setting, right? Conflict, coercion. And so I think it's important for us to recognize that when we're not doing a good job of having like a supportive unit environment where our workers feel supported, where we're paying a lot of attention to assuring that if there's events and individual workers or a team is involved in an event, they need a lot of work in terms of not just that moment debriefing, but studies have shown that both immediate social support for workers who are exposed, as well as ongoing for about 2 to 3 month support, shows a much lower risk of emotional outcomes or work-related negative outcomes. So thinking about how can we bolster social support among our teams that are working together. And for, our leadership, we have to think about this is an economic cost, right? This does hit your bottom line. And so it's really important. It does take time for staff to be able to have time together to process what's happening. I think of the huddles we might have, or the morning sort of turnover of report of what's happening, and sort of looking at these times and change of shift times as ways, how can we build in time that we can debrief, for example, before we go home, which will help our workers, kind of de-stress a little bit before they go home. Those kinds of activities, I think, are really important for our workers. The other thing is, if we're not focusing on validating the amount of intervention that's happening on a daily basis. So if you consider in any worker's work week, they're exposed to 6 events. That means that every single day they're getting some exposure. I sometimes have said, well, it's not like working in a bank, right? Where everybody comes to the counter and they're very pleasant and they want their money and you give it to them, and very little verbal aggression is happening, right? But we're in a setting where we have people who are very upset and distressed, and so we really need to sort of focus on how this unit is working on all those factors around how are we managing difficult conflicts that arise. I think, interestingly, with the safe words model, an interesting idea is this idea of not saying no. So avoiding no's. So how can we avoid no's with our patients? Because no's are almost automatic conflicts, right? Well, what do you mean I can't dry my hair or whatever, or I have to wait an hour to get my blah, 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 right? I remember all these, being a staff on an inpatient unit, there's a lot of times that it's really hard. And so examining, what do we really need to keep away from patients? How can we have freer, more open environments? How can we involve the patients in a kind of this assessment of our environment and safety? And I think we'll get to better places if we do things like that.
There's a big issue around the legal aspect of how staff members feel when they're experiencing aggression. Could you elaborate in terms of what strategies that some hospitals can implement, to both support the staff, but at the same time making sure that we're putting strategies in place to address that in a policy?
So do you mean in terms of will I press charges against a patient if I'm assaulted, that sort of thing?
Absolutely.
Yeah, so I think this is a difficult issue, obviously, because we have this responsibility for caring for people, right? And as workers caring for our patients, we really don't want to charge them with a crime, right? Charge them with assault. On the other hand, it is a worker's right, an individual's right to bring charges against someone for assault and battery. And I think so perhaps the hardest, the thorniest part of this issue comes when we have folks that we're trying to care for that are very aggressive. And I think, that's the time. There was an article that looked at the 6 core strategies. And what they talked about was that getting those leaders involved in the everyday consideration of what's happening with these most difficult patients is actually by itself, just Dr. Katzman and Dr. Khan coming into the units and saying, hey, let's talk about this. This must be really hard for you, in a supportive way to engage in problem solving. What do you think we could do that might help? Right. I think it's those proactive things, even in the midst of a really hard situation, that can help us to mitigate really the negative aspects, the anger, the desire to sort of retaliate. So I think we have to really be able to carefully address that. I think on the other hand, we should, I don't think we can remove the ability of our staff members to bring legal charges against some behaviors that occur. And so I think, what we want to do is carefully sort of work with folks around this and hopefully support them before it comes to a head in a difficult way.
Dr. DeSantos, what amazing answers. And there's so much interest in the audience. There's 20 questions hanging out there when we have just a minute left. So I wanted to ask you, first of all, if people did have a lingering question for you, would it be okay for them to send you an email?
Absolutely.
Great,
absolutely.
Great. Thank you.
And it's, my email is joanne.iennaco@yale.edu.
Great. Thank you. Thank you so much. Because I know.
Yeah, I'd love to talk more with folks. I see some of these questions.
Yeah, there are very wise folks out there who know a lot, and I think are very excited to hear you. I'll read, we just have a minute left, but I'll read one question from the president and medical director of Silver Hill Hospital, Andrew Gerber, who's really thanking you for a fantastic talk. And really shouting out to a Happy Nurses Week for everybody. And he says, I can't think of a more important issue than this as we consider how we can improve the level of psychiatric care for our patients and improving the work environment for our staff. He wanted to ask you a question about healthcare funding and advocacy. It seems to me that for too long as a society, we've looked the other way as inpatient psychiatric environments have gotten less safe, and government and commercial insurance payers are not reimbursing at the rates needed to provide staffing and training that are needed. Has your incredibly important work been presented to the payers as part of why we need better reimbursement rates? And we're at the end of our hour, so just even like 30 seconds on that. Great question.
What a great question. You know, as I look back over my career, you know, I've worked as long as the 80s, right? So I was in that part of the workplace in psychiatry where we were reducing the number of beds, we got rid of units, we only admit people who are most acute right now, all of these hugely problematic. And I want to say, I don't know if our settings have adequately considered, like, how are we managing these units differently now? Like, people need structure, they need regular interventions in their day-to-day. And it's often these things that actually are proactive measures to reduce aggression too. If people don't have much to do and they're, you know, whatever, you're more prone to have conflict and coercive interventions. So yeah, I totally agree. There is, I mean, even if we just took a snapshot of the inside of our psychiatric units compared to a snapshot of, let's say, the local cancer center inpatient unit, how different are they? Why is it that our units don't have single beds in most cases? You know, here we have people who are struggling and quite a lot of distress. You know, in Europe, in the UK, they actually went to every patient having their own room. And so you have a place, you don't need to seclude people because they have a room they can go to for some quiet and to de-escalate, right? And so there's lots of things around the funding that are problematic. And I agree, I hadn't thought to present to payers, but would be happy to. Because you're right, the financing in the equation of financing is a problem in our healthcare settings today, and particularly in psychiatry, where we're stigmatized, and I don't think we get the kind of funding we need. And then people wonder why there's terrible things happening in our communities with violence.
I know you'd have a resounding agreement from our audience out here on this. So thank you. Thank you again, Dr. Iennaco.
Can I ask something?
Yes. Yeah,
but someone copy those questions and answers, because I would love to see what people are saying, and we don't have time to see them all. But thank you all. I've really enjoyed talking with all of you today.
Thank you so much for such a wonderful presentation. And I can't really think of a more appropriate lecture in honor of National Nurses Week. And thank you again, Dr. Kan, for your partnership today, and to all of you for joining us. As a reminder, for those wishing to receive continuing education credits, please complete the evaluation survey that will automatically show up in your browser when the webinar ends. And until next time, this concludes our grand rounds. And Jane, if you could get a copy of those questions in the chat, that would be totally wonderful too. So thank you, everybody. Great to be with you, and we'll see you next time.
Thank you all.
Thanks again.
Have a good